All right, I know not everyone's back from the break yet, and I'm sorry, I know the lines for the bathroom were long, but we're just going to start to move forward just to keep somewhat on time. I know I keep giving sort of the same reminders, but I'm sure there are a lot of questions, and again, on the index cards, we're actually, for the second half, going to have some of our volunteers circulate with a little basket. So if you do have a card with a question on it after each talk, look for one of our volunteers with a basket, and we'll collect them and answer those questions for you at the end. Again, I can't emphasize this enough. If you've parked or valet parked, please make sure to pick up a parking voucher. And again, not to be mean, but at the end of our session, we're going to encourage you to go ahead and reclaim your cars at that time. All right, so our next talk actually is going to be a combined talk on the topic of spasticity. The first part of this talk is going to be by Dr. Faria Amjad, one of our faculty members here. She's actually a homegrown product of the Georgetown Neurology Training Program. She did her residency, I believe, and fellowship here. And is now one of our faculty members. In fact, she serves as director of clinical trials for the MS group, so she's really in charge of coordinating all of the different clinical trials and working with Lexi and the research team. She also is director of our Spasticity clinic, and she'll talk more about it, but she has a special skill set that allows her to help treat our patient with spasticity. So without further ado, Dr. Amjad.
Good morning, everyone. Thank you for coming. It's such a nice thing to see a large turnout, especially on a Saturday morning. So as Bob introduced me, I am the director of the Spasticity Clinic at Georgetown, and I have a special interest in spasticity. So that's what we will be discussing today. So the first thing to understand about spasticity is that it is not a disease in itself, okay? It is a symptom caused by any disease which can affect the brain or the spinal cord, okay? So some very classic examples would be a stroke, something very common in the United States, where a patient will lose blood supply to the brain. That leads to a stroke. Another example would be any traumatic injury to the brain or the spinal cord, such as after a car accident or after a fall. If anyone remembers Christopher Reeves, he fell off a horse and damaged the upper part of his spinal cord. It left him quadriplegic. He could not use his hands or his arms, he could not move his legs. And if I had a chance to examine him, I would probably be able to pick up a little bit of spasticity. Cerebral palsy is a very common cause of spasticity in the pediatric population, so in our children. And then when it comes to multiple sclerosis, we know that approximately 400,000 people in the United States live with MS, probably close to 2 to 3 million around the world, okay? Of that number, 70% will have spasticity. And 40% of that will have spasticity, which they consider to be problematic. And what I mean by that is interfering with their life in some way, okay? So the first thing to understand, as I said before, spasticity can be caused by any injury to the brain or the spinal cord. So let's get into why that happens. The brain and the spinal cord are really the essence of life. They control everything about us. And beginning in the brain or spinal cord, that's where movement begins. So the descending impulses begin in the brain or the spinal cord, and those impulses are eventually transmitted out to the peripheral nerves. Those peripheral nerves talk to muscle, those muscles contract, and that's what allows you to move. So what happens in multiple sclerosis, and usually spasticity is caused by lesions in the spinal cord. What I mean by lesions are those white spots that Susan showed you on the MRI. And those white spots can also develop in the spinal cord. And so as those descending impulses come down, they interrupt those impulses from getting to the peripheral nerves and to the muscles appropriately, okay? The best way I could demonstrate this to you would be if I had this glass. Obviously, the first thing I need to do is grasp onto the glass. I want you to ignore this part of my arm. I want you to focus here, the upper part of my arm. So in order for this glass to get to my lips, my bicep has to contract, right? And you can feel that on yourself. If you were to do this movement, you can actually feel the bicep contracting. The other thing that we usually don't think about is that there's another muscle that's involved, and that's your tricep. In order for the bicep to contract and for this glass to end up to my lips, the triceps have to relax, okay? If the triceps, which are here, do not relax, my arm is going to go flying the other way, and that glass will never get to my lips, okay? So the bicep and the tricep are considered antagonistic to each other. They are doing the opposite at the same time in order to accomplish a specific movement, okay? So in spasticity, because of those lesions that you have in the brain and the spinal cord, that circuitry, that coordination between the antagonistic muscles is interrupted, all right? And so let's say I have a spastic arm, and let's say my triceps is involved. When I try to do this, when my bicep is contracting, the triceps will contract concurrently, and either I will have a stiff limb, or whenever I try to do this, the glass is going to go flying out, okay? In a nutshell, that's spasticity. And so some of the manifestations of spasticity include stiffness. As I just demonstrated, you could have a very stiff limb. And it's not necessarily stiffness that other people may see or that you may have just with a certain movement, but it could just be a subjective sense of stiffness in the muscles, okay? My muscles just feel stiff. A second manifestation would be spasms, okay? And so these are sudden contractions of your muscle, all right? A good example of this would be when you are trying to transfer, let's say someone who is wheelchair bound or someone who can't use their legs or stand on their legs. You're trying to transfer them from the car to the wheelchair, and all of a sudden their leg kicks out, okay? That impairs the ability to transfer. It could lead to injury. It just causes discomfort. So that's an example of a spasm. You can have spasms where you kick out or spasms where you kick in. And again, this applies to the upper extremities as well. Go out, go in, okay? The other important thing to understand about spasms is that they can actually be painful. Not always, but they do have the potential to be quite painful. A third manifestation would be jumping. In neurology, we call this clonus. It's just an abnormal reflex which does not stop. The way I always think about this is if anyone remembers Thumper from Bambi, he used to thump his leg. That's kind of what jumping or clonus looks like. Sometimes it stops automatically. Sometimes you need someone else to exert pressure in order for that jumping to stop, okay? Cramping, okay? Cramping can be very painful. If anyone's ever experienced a Charlie horse or, like cramping in your feet, can be exquisitely painful and can be prolonged. And so imagine that someone who's living with spasticity who has those cramps and they just don't stop or they occur very frequently, okay? So ultimately, all of these things lead to a loss of control because if you're unable to contract your muscles appropriately, you're not able to move appropriately. And so you lose control over a big piece of your life. Okay. So among many reasons, why is it important to treat spasticity? There are many, and the first two I wanted to focus on, as I alluded to before, pain. Spasticity can be very painful. And if you're in pain all the time, your quality of life is not going to be so great. Number two, gait impairment, okay? Spasticity can definitely affect the way people walk and the way people ambulate. In MS, the way we gauge disability is heavily geared towards how well we are able to walk, okay? There's a scale called the EDSS, and that scale definitely has more focus on our legs and how we are walking, okay? So the way I wanted to demonstrate this was with this picture. So this gentleman, clearly there's something wrong with his right side. The arm is affected with spasticity as well, but what I wanted to focus on were his legs, his right side. So the first thing you're gonna see is when he's trying to initiate movement, he's got weakness of the right leg, so he's kind of hiking up the hip. The other thing that is not as apparent in this picture is that he's unable to flex that leg. He's unable to do this. To flex the knee, okay? So clearly when we walk, there are a lot of things involved, there are a lot of muscles involved. Specifically here, the quadriceps, which is your muscle here in the front of your thigh, is over tight, it's spastic. So it's not relaxing when it should. So when the hamstrings try to pull his leg in, the quadriceps remains contracted and keeps his leg kicked out, okay? So his leg is unable to bend appropriately. The other thing to notice is that the right foot is in this position. It's not coming up, it's not doing this, okay? That's because the calf muscles back here are pulling the foot down. They're not allowing the muscles over his shin to bring the foot up, even if the strength may be there, okay? So this is a very classic manifestation of spasticity. This patient could have MS, this patient could have had a stroke. I don't know. Again, the manifestation would be almost identical. Okay. Here I wanted to focus on the arm a little bit, and this is a very nice picture because it cuts up the arm into its different segments. The first picture is showing the elbow. It's like this, okay? The biceps are overcontracted, so they're pulling in his arm at all times. He's not really able to do this. His wrist is like this. It's flexed inward like this, and his fist is constantly in this position, or his palm is constantly in a fist-like position, okay? So what does that mean for function? Well, he can't do a lot of things. A classic example here would be he's unable to grasp onto his cane in order to walk appropriately. So again, could affect his gait, okay? So some other reasons for why it's important to treat spasticity. So skin integrity, that's best demonstrated by the fist-like position. Clearly, if your fingers are always like this and you're always clenched, you can't open your fingers. What happens over time? The nails begin to dig into the palm, can lead to cuts. Those cuts become a nidus for infection, okay? The other thing is he can't open the palm to clean. So that leads to bacterial and fungal overgrowth, and that can lead to malodor and embarrassing situations, okay? The other important aspect of treating spasticity is to prevent subluxation or dislocation of joints, okay? Spasms and spasticity can be so severe that they literally pull the joint out of their socket. I saw this recently in a gentleman who had traumatic brain injury. He was in a nursing home. He came to me, and when I examined his legs, I could see that the knee was dislocated out of its socket. So, important. The other thing is, if you're not able to move a joint, in terms of its range of motion, eventually the joint changes and then you might develop arthritis, you might develop capsulitis. So a classic example of this would be someone who's always like this, because he can't do this, they develop frozen shoulders, okay? And then when someone tries to lift them up, and if they exert too much force, you might actually begin to tear the tendons and the ligaments around the shoulder, so the rotator cuff is injured, and that in itself will lead to even more pain, okay? Nerve impingement, all right, that's best demonstrated with this second picture where the person's fist is like this. So we have peripheral nerves innervating every single muscle in our body. They allow our muscles to contract. But if you're constantly like this, you're exerting a lot of pressure on a nerve that traverses the wrist. It's called the median nerve. If anyone's ever had carpal tunnel is essentially compression of that median nerve. And so if your wrist is always like this, you might develop carpal tunnel. And that in itself can lead to further weakness and pain as well. Another classic example is compression of the ulnar nerve, which actually runs here. If you're constantly like this, that can lead to compression of the ulnar nerve. That leads to tennis elbow. Okay? And the list can go on and on. The last two things I wanted to focus on are muscle atrophy and joint contracture. So if you think of spasticity like a cast, right? When you break your leg, the doctor may put a cast on your leg or your arm or whatever. But if you're constantly in that cast, and if that cast is never taken off, and you're never able to move that leg, when you take the cast off, underneath, what should you see? Most likely, you're going to see that the muscles have gotten smaller. They've atrophied. They've shrunk, okay, because they haven't been used. That's exactly what can happen in spasticity if it's not treated appropriately. And if the muscle atrophies or if it gets smaller, it leads to further weakness, okay? And the last thing is joint contracture. So again, if your limb is not moved, if the range of motion is never used, what happens is that the joint itself will begin to change. And what I mean by that is that the soft tissue around that joint will begin to shrink. The ligaments and the tendons change. That's a mechanical problem. That limb will get stuck in place. There is nothing I can do from a medical standpoint in terms of the therapies that I have available to me to fix that. When people begin to form joint contractures, really the only solution to that is a surgical intervention where an orthopedic surgeon can come in and cut those tendons, all right? So it's invasive, it can be painful, and the third thing is it doesn't prevent future joint contractures from happening again. So that same joint can again become contracted. So the best way to treat spasticity is to catch it early on and to begin treatment early on in order to prevent contracture formation, okay? A few other things, a few other reasons to treat spasticity. So physical injury. I've seen spasticity so bad where the person's limb will sort of kick out. They can either hurt their caregiver. Sometimes if it comes in, they can actually punch themselves in the face. So again, other reasons to treat spasticity. Personal care and hygiene. I touched on this already with the clenched fist. But a few other things: toileting, dressing, incredibly important. If your legs are constantly stuck together like this, you're not able to open the legs to clean your private parts, all right? Toileting becomes difficult. Sleep disruption. For whatever reason, patients always tell me that their spasms are most severe at night when they're trying to go to bed. So getting restful sleep becomes more difficult, right? If you're not getting restful sleep, we know that MS already predisposes you to fatigue. If you're not sleeping well, you're going to be even more tired, okay? Another reason to treat spasticity. Weight loss. And I did not realize this. This is not something I read in the textbooks, but spasticity can be incredibly calorically demanding. It takes a lot to keep those muscles contracted at all times. And so patients who have very severe spasticity, something that I have noticed is that they come in looking very underweight. And when you begin to treat the spasticity appropriately, usually they start to regain a healthy body weight. And the last thing, body image, something that we as clinicians, I think, don't think about enough. How we look at ourselves, how we think other people look at us, I think is incredibly important. And that to me was best demonstrated by a young man. He was about 25. He had a gunshot injury to the back, and that led to spinal cord damage. He had severe, severe spasticity of his legs, and he would tell me that the spasms would be so bad that he would lose control of his bowels. And in fact, this happened to us in clinic. He lost control of his bowels, and he said that because of his spasms, he no longer wanted to go out in public because he never knew when he would lose continence. So for him, that was his main goal in terms of treating the spasticity. Okay. Things that can worsen spasticity, exacerbating factors: staying still, not moving, not stretching, will worsen spasticity, okay? Temperature, extremes of temperature, so hot temperatures, typically it's extremes of cold that will exacerbate spasticity. I mean, if you think about it, on a cold morning, you're probably stiffer compared to a morning in July. Okay, your muscles just sort of stiffen up a little bit. And that's another reason when you wake up in the morning to stretch, it warms up the muscle, okay? Infections, we know infections can worsen MS, they also worsen spasticity. Pressure sores, ingrown toenails, constipation, something a lot of MS patients will suffer with. Constipation can worsen spasticity. So if you just alleviate the constipation, maybe you can help the spasticity as well. Pain, again, something I've touched on repeatedly. Tight clothing or ill-fitting orthotics, and stress and emotion can worsen spasticity. Okay, so whenever I see a patient in clinic, the way I approach the problem is, one, I want to figure out whether you actually have spasticity. And that's done with a good history and a good physical exam. Once we've established that you suffer from spasticity, the next question I'm going to ask is, how does it bother you? How is it impairing you? Is it impairing your ability with good hygiene in terms of cleaning? Is it walking? Is it pain? What exactly is the problem? And there may be multiple, but we have to choose one thing at a time to work on. Okay? We're going to figure out what treatment you're on right now for the spasticity. We'll figure out whether it's working. I'm going to ask about what you've been on in the past and why those treatments may have failed. Okay? And then we're going to establish goals. Again, picking one or two goals at a time, working on those goals in terms of functional goals. And this is not going to be solved in one clinic visit. It's going to take multiple clinic visits. All right? There are some benefits to spasticity. So if you remember my analogy of spasticity being like a cast on your leg, that cast actually can be very supportive in you walking, right? So I don't necessarily want to over-treat the spasticity. It might be helping. And so it's a balance between treating the tight muscle without making you too weak. And it's a fine line. Okay? So what treatment options do we have available to us? So stretching and exercise, incredibly important. Stretch out those muscles. Stretch out the muscles that are over tight. Strengthen the muscles that are weak. And it's extremely important. I think Lisa's going to talk more about that. Some of the oral options that we have available to us, and I'm sure some of you have actually been on these medications already. Baclofen is probably the most popular, and then the list can go on. The issue with these medications is that they're oral, okay? So let's say you just have spasticity affecting the leg or the arm or the hand. Well, you don't necessarily, all of that oral medication may not be helping you because it's affecting all of your muscles, okay? Number two, a lot of these medications actually don't get into the central nervous system. They don't get into where the problem is, which is with the brain and the spinal cord. A lot of it is just wasted medication you excrete out. Number 3 is that they come with their own side effects. So a lot of these medications can lead to sedation, sleepiness. They can lead to further cognitive impairment. They can lead to further weakness. And you also have to make sure that the person's kidney and liver function are okay before you start them on these medications. Okay. So more focal approaches that we have to spasticity include nerve blocks. So that's best demonstrated with here. So that's a nerve block. So basically it's an injection of lidocaine that's given directly to the nerve. Nerve blocks are very good. The problem with nerve blocks is that they don't last long. The effect does not last long. It might last a few minutes to maybe just a few days. The second option would be phenol injections. Phenol injections are typically given directly to where the muscle and the nerve meet. Phenol injections are very good in the sense that they last a long time. They can last anywhere from 6 months to 36 months. The problem with phenol injections is that they're pretty toxic to the nerve itself. They actually cause the nerve to begin to die back. Okay? The other thing with phenol injections is that they can lead to local tissue and circulatory damage if done repeatedly. So phenol injections, we actually don't use them very commonly at Georgetown. The thing that we do use a lot of is botulinum toxin. This is also known as Botox. Botox is the same medication that's injected into people's faces to get rid of the wrinkles. Because wrinkles are just over-contracted muscles. You inject Botox, the wrinkles smooth away. That's how it works. So Botox has many uses. It's not just used for wrinkles, it's used for cervical dystonia. It's used for sialorrhea, where people drool too much. It's even used for hyperhidrosis, where people sweat too much. I will use it for spasticity. So this is a picture of someone injecting Botox. That's the needle. The 2 leads there are not to shock you. They're to pick up the muscle activity. So we know, okay, this is muscle, and this is the right muscle. And then we can inject it. So the nice thing about Botox is that we can play around with the dose. So I have flexibility over what I'm giving you. And it's a focal approach. I'm going directly into the muscle that might be affected or might be problematic. So you're, like the oral medications, which are systemic, this is a very focal approach. Botox typically will only last about 3 months. Okay? The downside of Botox is that it has the potential to lead to weakness, because when I relax the muscle, inadvertently I'm also weakening the muscle. Now, typically that doesn't happen if you know what you're doing and you use the dosages judiciously, but it has the potential. Even if that happens, typically the weakness should only last about 3 months. The other thing about Botox to understand is that with repeated injections, I could probably increase the interval even longer. Maybe we can go 4 months, maybe we can go 5 months. Okay? This is an intrathecal baclofen pump. It's the size of a hockey puck. It comes in 2 different volumes, a 20 ml pump and a 40 ml pump. So baclofen pumps hold liquid baclofen. So this is the same medication that we take orally, but it comes in a liquid formulation. It comes in micrograms versus milligrams, which is what you would take orally. Now you would think, well, it's less. Now, it's not less. The reason is it's more potent because the baclofen is getting directly into the spinal cord. This is a cartoon showing the baclofen pump actually implanted. There's a catheter that comes out and it snakes its way into where the spinal cord sits, which is again where the problem is coming from. And it squirts out little bits of baclofen. The nice thing about these pumps is that we can talk to it. There's a remote control I can put on top of it and I can adjust the dose. Again, there's flexibility. The other nice thing is you can put in even more flexibility. Let's say you have spasms that are more common at night. Well, okay, I can give you a little extra at night to make you sleep well. Okay? This is a cartoon of what the pump would look like once it's eventually implanted. So it sits underneath the skin in the subcutaneous tissue and fat. You don't actually see it, but you can feel it, and that's how we also refill it, because you could think of the baclofen pump like a little tank of gas. Just like your car, it's eventually going to run out, and it has to be refilled. Okay? You don't see the catheter, you don't see the pump. All of that is inside, and it's implanted by a neurosurgeon. Okay? Physical therapy and occupational therapy, again, we have Lisa Ebb here. We're very lucky to have her. She's going to go into more about that, but I just wanted to make one note. Our physical therapy and occupational therapy colleagues are essential to what we do. We work together with them, and I can't say enough about them. And the last thing I wanted to end on, we talk a lot about MS. We don't have a cure, obviously. We spend a lot of time talking about the medications that we have available to us, how they work, their risks, their side effects, their benefits. But the other thing about treating MS is making the quality of life for that person better. And the way we try to do that is with symptomatic management. And I think that's really all we're doing all day, is trying to improve someone's quality of life. And with that, I'm going to turn it over to Lisa.
Thank you and welcome this morning. Thank you, Dr. Amjad, for that warm welcome. Just going to get to. Is that better? Yeah. Okay. And Okay. So I'm going to talk about spasticity and physical therapy. As you can see from the title of my talk, I will be discussing the treatment options from the therapy perspective. Generally, it will be your neurologist that will refer you for therapy for a myriad of symptoms, one being spasticity. Alternatively, I can also refer you back to your neurologist if I see that spasticity is interfering with your function, your daily mobility, and your quality of life. So how can therapy help with the treatment of spasticity? The goals of therapy are to decrease pain, prevent or decrease contractures, improve ambulation, increase safety, reduce caregiver and family strain, and most importantly, increase function and improve quality of life. So as Dr. Amjad mentioned before, spasticity is not always a bad thing, so we need to assess how the spasticity is affecting your function and mobility. So at the evaluation, as a physical therapist, I'm going to look at you in 3 different positions: resting position, lying down and sitting, standing and walking, because your spasticity can change depending on what position you're in, and it can affect your function. In addition to looking at spasticity, we also look at other areas. We look at strength, flexibility, pain, balance, walking, posture, bed mobility, and transfers. One big thing I want to illustrate is the difference between flexibility and spasticity, or muscle tightness and spasticity. So if we use the arm, for example, when I'm looking at the biceps, if the biceps has a lot of spasticity to it, it's going to be contracted. And if I want to stretch it out, I'm going to stretch it out. And if I feel a constant tension throughout that movement, that's more muscle tightness. But if I change the movement at varying speeds and I feel different muscle tension at the varying speeds, that's more spasticity. And that's how I can disassociate the flexibility or the muscle tightness from spasticity. So therapy treatment options. Excuse me. So we have a bunch of different options that we can choose from, including range of motion, stretching, strengthening, massage therapy. And I say massage with a caveat that it should not be the only treatment of your spasticity. It should be in conjunction with stretching and strengthening. Aquatic therapy, there's actually a lot of PT literature that shows that spasticity is reduced in pools that are between 80 to 82 degrees. Our Yates Fieldhouse, our pool here is 81 degrees, so we do offer aquatic therapy here at Georgetown. I can't say that I'm one of the aquatic therapists, but we do have other aquatic therapists here that it's a regular therapy session, but it's in the pool instead of on land. We're also going to talk about positioning and orthotics in further detail. One other thing about stretching is the MS Society on their website has excellent handouts, illustrated handouts and instructions for stretching with MS and caregiver stretching. So I encourage you to look at those handouts because they give detailed pictures and written instructions on how to do stretching. If you're in therapy, we will also give you a home program on stretching, strengthening, flexibility, mobility to manage your spasticity. So positioning in bed. So like Dr. Amjad alluded to earlier, a lot of people have more spasticity at night, so it's hard to get comfortable. So here are some different pictures of different pillow positioning to make you more comfortable with your spasticity. How many people are side sleepers? Okay, now be honest with me. How many people actually put a pillow between their legs when they sleep on their side? Wow, okay, great. It's actually better for your back to put a pillow between your legs because it puts your back in a more neutral position, and it reduces the rotation of your spine. If you are prone to extensor spasticity in your legs, meaning your legs are out straight, you want to bend your top knee to break up that extensor spasticity and put a pillow between your legs the long way. In addition, if you have some spasticity in your adductors or your inner thigh muscles, or your knees tend to roll inward, that's another indication for a pillow between your legs the long way. If you have flexor spasticity, meaning your hip and knee are bent up more, you still want to put that pillow between your leg, but you want to straighten your leg as much as possible to a position of comfort. With spasticity, you don't want to force yourself into that position. You want to get yourself into the position and kind of let those muscles kind of settle into that position. Never force it, because that could be an indicator for pain, and then your spasticity will actually heighten. How many people lay on their back? How many people put a pillow under their knees? How many people put a pillow under their calf? So one reason to put a pillow under your calf as well is to get the pressure off the heel, okay? Because that can be an annoying feeling over time, overnight. So I often recommend putting a small pillow under your knees. You don't want your knees bent up too much, because that can encourage the flexor spasticity. But a pillow under the calf to float the heel can reduce an irritation to the heel. The other thing I really like to put out is the position of your head and neck will also encourage spasticity. For example, does anyone sleep with no pillows? Excellent. Because if you don't have a pillow under your neck, it will actually bring your head and neck into extension more, which will increase your extensor spasticity. You want your head and neck in a neutral position. When you have pillows under your head, you don't want them under your shoulder blades, because what that will do is that will give you that more rounded forward posture. So you want the pillow to be behind your head and right up to your neck, right above your shoulders, and you kind of want to push it in, whether you're on your back or on your side. If you need more than one pillow to sleep for comfort, that is fine. Just make sure they're not under your shoulders, they're creviced in your neck. For your arms, if you have the flexor spasticity, you want to try to get your arm away from your torso. So sticking a pillow in your armpit the long way between your torso and your arm will help position your arm better, so there's more room, it'll be more comfortable and protects your forearm. Now, obviously, you're going to start in these good positions at night. Will you end up there in the morning? Probably not. But it's really good to start in a good position, and if you wake up uncomfortable, try to reposition yourself as best as possible. You know, we want the ideal, but the ideal isn't always necessarily reality. So this is kind of near and dear to my heart. This is what I do as a physical therapist. So orthotics can be beneficial if you have weakness in the front of your foot, like the picture that Dr. Amjad showed you earlier, where the foot was pointed down more because of spasticity in the calf. It's like an unbalanced seesaw. If you think of a seesaw, think of the spasticity in the calf on one end, and then the muscles in the front of your foot trying to pull your foot up. Whether there's weakness in the front of the foot or the spasticity is just too great, there's an imbalance. The front of the foot cannot fight against that spasticity, so you have an unlevel seesaw. That's where orthotics, lower extremity orthotics, can be beneficial for positioning and also for safety and fall prevention. An AFO, or an ankle-foot orthoses, will provide support to joints and help maintain proper postural alignment for safe mobility. So, like Dr. Amjad said before, you also want to make sure that your orthotic is fitting appropriately, because an ill-fitting orthotic can also increase spasticity. So as a physical therapist, I not only assess the fit of an orthotic, but also recommend and prescribe a new orthotic if it's warranted. So a couple of different orthotics that you'll see on the screen. If you look at your far left, that is a solid AFO, or a solid ankle-foot orthosis. That's a custom-made orthotic that you need a prescription for, and you would be referred to an orthotist who would cast you for that orthotic. This is better for people that have more weakness in their ankle. It gives you more support and possibly reduced ankle range of motion, where it provides that stability as a joint. The other custom-made orthotic is a hinged AFO. So it actually looks like you have an ankle joint. The top part of that brace can flex forward and backwards. This is better for someone that has stronger hips, that has that stability proximally to have that mobility in the ankle, because you essentially still have a true ankle joint. So those are the two custom AFOs. An off-the-shelf AFO, which you see to your far right, one example is called an Allard. It's a carbon fiber AFO. It is lightweight. It is very easy to fit in a shoe, but it gives you the least support. So as a therapist and with you discussing your goals, we determine what's the most appropriate AFO for you. Unfortunately, the negatives about custom AFOs is they are heavier, they are hard to fit into shoes, and they give more warmth in your shoe. On the bottom, you see a multi-POTUS boot. So the top three AFOs are for walking and standing and positioning and balance. The bottom picture, a multi-POTUS boot, is for positioning only in bed at night. You do not walk on a multi-POTUS boot. If you see, I don't know if you can see, but coming from the left, there's like a plastic stay. So what that does is when you have that boot on, that plastic stay leans against the bed, so it keeps your foot upright. Okay, so that's another way to float the heel in addition, but also position the foot. So when you're sleeping at night, your foot will naturally kind of want to flop down. Gravity will pull it down. This is a nice way to maintain length of your calf muscles in bed at night in that positioning boot. Just for an example, I actually had a patient referred to me by an orthopedist. The gentleman has MS, and the referral said hamstring tightness. So I get him on the table, I look at his hamstrings, and his knee goes completely straight, and I'm like, I'm not seeing any hamstring tightness, And then I look at spasticity, and he has a lot of hamstring spasticity, but I couldn't provoke it. And he was saying, I was having a lot of spasticity at night. So I do my further assessment, I have him go on the table, I take off his shoes and socks. He has a pressure wound on his ankle. Every time I touched that, his foot came up. So he didn't really he had spasticity, yes, because it was from the pain from the ankle. So treating that wound actually reduced his spasticity, and we gave him a multi-POTUS boot because that wound was from his foot kind of sideways on the bed. That pressure from the ankle bone on the mattress gave him a wound, which was increasing his spasticity. So these devices can be very helpful for positioning and to reduce spasticity. In addition to orthotics or AFOs, as a PT, we also recommend the most appropriate assistive device for safe mobility, whether it be trekking poles, a cane, a walker, a rollator. So it really is what our goals are in working in therapy and what's best for you for your function and your quality of life and activities that you want to be able to perform. So upper extremity orthotics, so like the multi-POTUS boot that I showed you a second ago, the resting hand splint, again, is for positioning. If you have flexor spasticity, like Dr. Amjad showed you those pictures of the hand fisted, the thumb in, a resting hand splint is a great positional device to reduce contractures and to maintain that hand in an open position. That can be worn during the day as long as you don't need to use your arm for any functional activities. If your spasticity is interfering with function, two things that I like to recommend to my patients. One is a universal cuff. So if it is really hard for you to open that hand up to, say, brush your teeth, to eat, to comb your hair, a universal cuff is a Velcro strap that wraps around your hand, and there's a slit to put something in it, whether it be a toothbrush, a comb, as you see there, a spoon. So you can still be independent in feeding yourself and grooming yourself with this piece of adaptive equipment or orthotic. The other thing is we have built-up foam. So if it is hard for you to have that fine grip and you want something with a bigger grip, it's just foam that we stick on pens, on spoons, on toothbrushes that allows you to have that bigger grip to have that motion to complete your ADLs or your morning routine. So this is near and dear to my heart. So about 6 months ago, we started a seating and mobility clinic at Georgetown. There are a bunch of different options for wheelchairs. One of my big soapboxes is, please don't go to the internet and buy a wheelchair, because based on Medicare rules, and most insurances follow Medicare rules, you're only eligible for a wheelchair every 5 years, or unless there's a significant change in status. If walking becomes too taxing and you notice that you're having more falls, a wheelchair is another option to maintain independence. I know some people see a wheelchair as losing independence, but think of it as if you can propel, whether it be a manual or a power wheelchair by yourself, this is giving you independence to be able to move around your home, your community, without necessarily the need of additional support. The other great thing I like about wheelchairs is it assists for positioning for spasticity. Like we talked about earlier, like especially with at night with sleeping, certain positions can increase spasticity. So being in a proper fitting wheelchair or seating system can reduce spasticity. And that is it. Thank you very much.